Well, thank you very much for the invitation. I really do appreciate being able to talk to you. And I hope that you speak up as soon as you don't understand something or have any question at all. I'll be talking about cancer prevention and treatment. And basically, I'm talking about a change in perspective in the topic of omega-3s.
Can you check whether the microstone is on or off?
It's on. That's what he says. A change in perspective from the stuff that you eat to the stuff that's in you and how to measure that. Okay. This is my conflicts of interest. The main conflict of interest is my lab. Okay, when we're talking about fatty acids, we are talking about the cell membrane. You all know that the cell membrane is fatty acids. And there's proteins sitting in the cell membrane, and the function of these proteins is modulated by the composition of the fatty acids that surround them. This is, for instance, true for ionophores. And it takes ion channels. How many ion channels do you need for one heartbeat? A dozen. So you want them to work properly, right? So you better keep them in their favorite milieu. There's a myth about omega-3s, and that is that the plant-derived alpha-linolenic acid is being metabolized into EPA and to DHA. These two come from fish. This actually happens in rodents, but it does not happen in humans. You can tell a difference. It was first found in rodents, and that's why it's in the textbooks. But for humans, dogs, horses, cats, and so on, it's not true. Alpha-linolenic acid goes into energy, and we depend on supply with DHA, for instance, to maintain our brain, which consists of DHA largely. And EPA and DHA go into the cell membrane and not only modulate the function of the proteins, but also are precursors for many bioactive molecules, truckloads of molecules. And that's why around the world, including WHO, all the experts say people should ingest EPA and DHA every day. Now, if you look at the dose that's being recommended, it varies between 40 milligrams a day and more than 2,000 milligrams a day. So they're not all that sure about the dose. And if you recommend a dose, you think that what you put into your mouth goes into your body, which is not necessarily true, especially not in the case of omega-3s. For instance, if you start your fat digestion, then yes, you can take omega-3s up. And if you don't, you don't. For instance, if you have capsules with your usual breakfast, which does not include 2 eggs, I would assume, then you won't absorb them, the fatty acids in the capsules. And that's a factor of 13. And there's been quite a lot of money that's been thrown down that drain. And the other very important thing to consider when looking at omega-3s is that there is an inter-individual variation in uptake up to a factor of 13. So what you take up is vastly different from what you take up in you. So intake is loosely correlated with uptake. The individual bioavailability is not predictable, and therefore you have to individualize dosing. It's quite simple, actually. So these recommended dosages don't help anybody. And besides, as a cardiologist, I am absolutely sure that hearts are not perfused with foodstuff. They're perfused by blood, right? And that's why we decided to measure in blood. And we wanted to measure in a cell that has a slow turnover in terms of fatty acids. So that is to say, we are measuring hemoglobin A1C and not blood sugar. We have the idea of having a standardized fatty acid analysis drew a lot of attention in the scientific area, and we have a lot of collaborations from all sorts of groups around the world, and they publish, and they keep publishing. The good thing about this parameter is that the biological variability, as I said, is low. It's much lower than the biological variability of fatty acids in the plasma, for instance. And by working and tweaking the method, we got down to an analytical variability that's acceptable to a clinical chemist. And why that is important is being illustrated by the results of this meta-analysis. Total mortality and levels in bloodstream of EPA and DHA. And if you look at what has been measured in the red blood cell, you get a clear-cut result. If you look at what has been measured in plasma cholesterol esters or whole plasma, you don't get a clear-cut result. Same thing is true for risk for developing type 2 diabetes. If you measure in adipose tissue or in triglycerides or in cholesterol ester, you don't get a clear-cut result. And what's even worse is what nutritionists use, their questionnaires. They are far from being science, actually. So if you want to have a good signal-to-noise ratio, you need to have a biomarker that has a low biological variability and an analytical procedure that has a low analytical variability. And that's a bonus. The red cell in terms of EPA and DHA is representative for every other cell that has been looked at in the human body, or in an animal's body for that case. So you don't need a brain biopsy, you just analyze the fatty acid composition of the red cell and you know whether the brain has enough DHA in it. Now there's a lot of labs out there that said, well, measuring fatty acids, that's easy. So we're going to do that. For instance, Cincino does that. And we keep sending samples to the other labs in the field. And what we get back is this. There's no relation to what we get as results. And in the case of Cincino, the results are not even reproducible. So, but if you use our method, what you get as a result, if you measure a number of people, is what you expect. You find a statistically normal distribution. But what you did not expect, probably, is that there is not a single human being out there or in here that has no EPA and DHA in the red cell. So this, in terms of investigating it, investigating this topic, is not a drug. Because in a drug trial, you test the presence of a drug versus the absence of a drug. And clearly, everybody has a presence here. So you have to design the trial more intelligently than you would design a drug trial. And that's the reason for the inconsistency of results, because a lot of people ignored this phenomenon. Okay, everybody has an omega-3 index. That's why EPA and DHA are vital. And based on cardiovascular data, we defined the target range for the omega-3 index to be between 8 and 11. In our area, 3/4 of the population are below, a fifth is within the target range, and a few are above. And if you look around, that changes from country to country and from population to population. For instance, in South Korea and in Japan, the majority of the population lives within the target range that we defined. And you might have heard that these people live longer, they have less dementia, they have less myocardial infarction, they have less sudden cardiac death, and so on and so forth. Canada, which is the country that consumes the most alpha-linolenic acid, the plant-derived omega-3, has a very low omega-3 index. So that's on a population basis. That's the evidence that alpha-linolenic acid is not converted to EPA and DHA. In the USA, people are slightly above 5. In Spain, around 7. In Germany, we are around 5.5, 6. And of course, there's special populations like the vegans who don't ingest any source of omega-3s, so they're very low. And the other extreme are the athletes. They have a low level because they burn a lot of calories and burn them including omega-3s. That's not just because of that number, there's additional evidence to support that statement. Now, if you look at mortality from the perspective of levels of omega-3s, you will find that all-cause mortality is lower with higher levels of EPA and DHA. And that's also true for cardiovascular mortality, but it's also true for cancer mortality and for other mortality, for instance, suicide. There's no effect whatsoever of alpha-linolenic acid, but the longer chains, they drive the game. Talking about mechanisms, you're more familiar with the mechanisms than I am, and it's the usual suspects that pop up here. If you increase the levels of EPA and DHA, you will find a shift in the eicosanoid system towards less inflammation and less angiogenesis based on these metabolites and others. And you will also find that cytokines, anti-inflammatory cytokines, and inflammatory cytokines play a role in the genesis of tumors, be it breast cancer or any other cancer. As I said, you know that better than I do. And the whole thing is that there is not one mechanism of omega-3s, there's many of them. An important thing is that transcription factors are downregulated usually, for instance, NF-kappa B, that you have changes in gene expression for instance, pro-inflammatory cytokines. You have a reduction of the levels of pro-inflammatory cytokines, and so on and so forth. So it's more than just one thing that's happening, it's a lot of things that are happening, and that goes back to the cell membrane providing the substrate, in this case, like leukotrienes or prostaglandins, and acting on, for instance, signal transduction and so on and so forth by changing the fatty acid composition of the membrane.
One question, what is PUFA?
That's polyunsaturated fatty acids. Now, for a long time, you could read in the lay media that omega-3s would increase prostate cancer, but they don't. This is an epidemiologic study from the Cooper Clinics. Maybe somebody heard about the Cooper Clinics, one of the biggest prevention centers in the US. And there is no relation between levels of omega-3s in the red cell measured with our method and later development of prostate cancer, in this case 5,500 men in an observation period of slightly more than 5 years. And there is a meta-analysis that put together all these studies demonstrating exactly the same. And if you look at animal models, omega-3s seem to reduce tumor growth and vascularization of the tumor. The things are different with breast cancer. Now we know that if you take quintiles of red blood cell fatty acid concentrations and use the lowest quintile as a reference, you will find that in the highest quartile in this case, the frequency of, or the risk, I should say, for breast cancer is about half, with higher levels of EPA and DHA. Same thing in a more pronounced fashion from Japan, 30% risk or 6% risk, which is hard to believe, but we don't really know. But we do know that meta-analyses support these two studies, and there is a lower risk for breast cancer with higher levels of omega-3s. And there's a level effect association per 1% omega-3s. The data, of course, I would say, are less clear if you look at consumption of omega-3s because of this variability in bioavailability, the individual variability, and there is a 20% reduction overall. I shouldn't say reduction, I should say less risk. Similar for colorectal carcinoma, in this case, tertiles, adenomas first. All adenomas, no correlation, but advanced adenomas are less frequent in the ones with higher levels of omega-3s. And colon cancer, again, in tertiles, depending on the fatty acid you look at, between 2/3 and 1/3 risk to develop colon cancer with higher levels of omega-3s. Supported by meta-analyses. And that's new data, that's only a single study. Healthy controls in non-small cell lung carcinoma, more likely with higher levels of omega-3s, or with lower levels of omega-3s. The lower levels in serum in this case. And right, the advanced non-small cell carcinoma is even more likely with lower levels. So that's the epidemiologic data. Now we come to treatment of cancer. And one form of treatment, you all know that better than I do, is surgery. And there's been a lot of intervention trials giving omega-3s either around the operation, after the operation, before the operation, and the effects are quite similar. This is a meta-analysis, and you would find that infectious complications, non-infectious complications are less frequent when omega-3s are given. There is a shorter hospital stay and the mortality is even lower. And this has been confirmed in other meta-analyses. This goes for infectious complications again, and this goes for length of hospital stay, and this goes for the inflammatory reaction as measured by the usual suspects in terms of cytokines. And this goes for operating lung cancer. Non-complicated group is higher in the ones who received omega-3s around the operation than in the ones who did not. Next treatment form, radiation and chemotherapy. This is an intervention trial in 48 breast cancer patients, and they got, during the chemotherapy, 1 gram of EPA and DHA versus placebo. And the parameter that was investigated in this case was total mortality, and survival was better with omega-3s than without them. And that's also true for disease-free survival time. These are the usual parameters that you use, right? For lung cancer, very similar data in terms of body weight, better maintenance of body weight, and reductions in pro-inflammatory cytokines. The other things that were considered were neuropathy. There's less neuropathy with omega-3s than without them. And there's less muscle loss and a better quality of life with omega-3s than without them. Pancreas carcinoma, basically the same thing. Right. And this is the original data for neuropathy during platinum therapy. And of course, and that's data derived from chronic inflammatory diseases, omega-3s have an effect on pain reception. They have a slight antidepressive effect. And that's one of the mechanisms behind that. And that's one of the meta-analyses that clearly demonstrates a positive effect for omega-3s on pain. So this is a cartoon that was published in 2015 that giving omega-3s to patients during chemotherapy or radiotherapy makes them lose less weight, improves their body composition, reduces their pro-inflammatory cytokines, and this is one of the mechanisms behind less complications in surgery, and improve quality of life for these patients. And there's preliminary data also out there demonstrating that with omega-3s, it's possible to give more cycles of chemotherapy, for instance, in breast cancer. So the survival gets better because therapies can be more complete than without omega-3s. And that's just one trial that has been published April last year. A Swiss group looked at the potential prevention of invasive cancer and tested omega-3s, vitamin D, and training as components of a integrated approach. And it was found that omega-3s plus, for instance, a self-administered home exercise program reduced later development of invasive cancer. If you have positive effects on one side, you should look at safety and tolerability and weigh that against each other. And yes, if you overdose omega-3s, for instance, an omega-3 index of above 16, you would generate bleeding episodes in 0.1% of the patients per year. That's 1 per mil. It's not that many, but the bleedings can be nosebleeds, but can also be intracerebral bleedings. So I would advise against very high levels of omega-3s, against a level of above 16 because of the bleeding problem. And the other thing that was in the lay papers last year was new onset of atrial fibrillation, and that was looked at in the large cardiovascular trials. And yes, there's a 50% increase in new onset of atrial fibrillation with high doses of omega-3s, but no increase in stroke, which is the most feared complication of atrial fibrillation. And there you have to know that the relationship between new onset of atrial fibrillation and the omega-3 index is U-shaped. So if the levels are low, you're more likely to get atrial fibrillation. If the levels are very high, you're more likely to develop atrial fibrillation. And guess where the risk is minimal? It's in the target range. So that's an argument for determining the omega-3 index also from the safety perspective. The regulatory authorities, European Food Safety Authority, they still consider doses and say they are safe up to 5 grams or 3 grams a day. That's the US FDA. And I would put against that, just stay in the target range, you get all the benefit without the risk associated with omega-3s. And tolerability and bioavailability are maximal if these omega-3s are taken with the main meal. Let me sum this up. A high omega-3 index correlates with low all-cause mortality and with low mortality from cancer. We have a number of established mechanisms of action, but there might be more than the ones that have been found. Prostate and gastric cancers are not more frequent with a higher omega-3 index. Breast cancer risk depends on the levels of omega-3s and is lower with higher levels. And there is one trial that demonstrated better survival with omega-3s in addition to conventional treatment. Lung cancer risk is lower with higher levels of EPA and EHA. Same thing is true for colorectal carcinoma. In surgery in gastric and lung cancer, you have fewer complications when EPA are given perioperatively. It doesn't matter whether it's being infused or given orally. Complications are reduced. In radio and chemotherapy are tolerated better. There's a better quality of life, less loss of body weight, less neuropathy, and might even be more effective with omega-3s than without. And the first RCT demonstrated prevention of invasive cancer with EPA and DHA plus a self-administered home exercise program, and vitamin D increased the effect. That's the target range, and it's safe, and bioavailability is best with the main meal. And there's a host of other positive effects of omega-3s. I'm a cardiologist. I tend to like cardiology data, but it's also true for the brain, for fertility, in pregnancy, DOBS, that is muscle soreness, muscle loss, non-alcoholic fatty liver disease, joint problems, eye problems, and so on and so forth. So there's, I would say, windfall benefits for the ones who get omega-3s because of their cancer treatment. And that's as much as I wanted to talk to you about, and I'm happy to take questions.
Es gibt keine Patienten, es gibt keine Therapeuten, es gibt nur Menschen.